Hi, I'm here today with the New Zealand physiotherapist Mark Laslett. I met Mark the first time, I think it was back in 2006, Mark. We're doing a course in Aalborg in Denmark.
Oh, yes.
Yeah, I think you just recently probably finished your PhD at that point.
2006, yes, 1 year.
Yeah, yeah. I remember you were there with Tom Peterson. And the both of you were talking about diagnostics, and a few years prior to that, I've just been out of school 1 year, and a few years prior to that, as my thesis, I was actually writing about Tom's new diagnostic system.
Yes.
With some of my fellow students. And then when I started working, I remember it was my boss and a colleague that says, "Oh, this Laslett guy, he's coming to town. Do you want one of the few seats that are there? Then you got to go now." And I remember I guess I was the only one just fresh out of school, and I was sitting in that room, and everybody else was quite experienced, from 5 to 20 years of experience. And there was this elderly rheumatologist, Gorm, who was arranging it all with Uffe Lindström. I don't know if you remember it all.
I remember Uffe Lindström. I don't know about the other guy, but Uffe I knew, yeah.
Okay, yeah. And you presented the diagnostics, and I guess that was like, I think I've always been quite curious, but the diagnostic process, my curiosity to that started just after I finished school, because I think when I did my undergrad, I was more keen on what I could do with my hands.
You're a physiotherapist. That's how we're trained. That's what.
Yeah,
yes.
but I think that's kind of my interest ever since has been into the diagnostics.
Okay.
And of course the management afterwards. But the diagnostics has always been interesting. And that's one of the reasons why it's very interesting to talk with you today. But before we dig deeper into that, Mark, could you just give a very brief summary of your career? Because you've been around for 50 years, as you said before.
Yes, it is a long time. Yes, well, I qualified as a physiotherapist in 1971, and within 5 months, I took over a practice in Auckland, and I leased that practice for 6 months, and then I bought it 6 months later when I was 22 years of age. And I've been in clinical practice really since then. I've had side journeys here and there, but I've been in clinical practice. I regard myself primarily as a clinician, although lately I would call myself a clinician scientist, perhaps. That might better describe me. I own my own clinics, and I continued to own my own clinics for 30 years, and I sold them in order to go and do my PhD, and that was in the year 2001. So I was in practice for 30 years before I did my PhD. And then I did that basically on an invitation from Birgitta Öberg in Linköping, in Sweden. And I had been going there on a yearly basis, basically to teach the McKenzie approach. And we had struck up a reasonably good relationship, and she was interested in some of the things that I had been doing in terms of research. And she is the one actually who recommended that I actually have a crack at doing a PhD. And my first reaction to that was, what on earth would I want a PhD for? I mean, seriously, we don't get paid anymore to have a PhD. We don't. There's no. I mean, apart from getting a label of doctor, it doesn't add anything to me at all. And she says, "Well, you're going to be doing the research. You're going to be doing the work. You might as well get the label." And I thought, well, that's fair enough, I suppose. So I came back to New Zealand, and I looked at the local universities, and they were requiring me to do a PhD in anatomy or in biochemistry or in engineering, and you have to do it under some sort of a rather sort of structured way. And I was completely uninterested in that. It just didn't interest me at all. I had research that I wanted to do. Had become already fascinated by the problem of trying to know where the pain is coming from, basically, and had already done some work in that area, and with Dr. April in New Orleans. And so I went back to Birgitta, and she said, "Well, you can do it out of Linköping." I said, "Well, I live in New Zealand." And she says, "Well, that's okay. You can sort of come and come and go as you usually do, and that's fine, and we can do it all by correspondence and what have you. And the other thing is, I was doing all my research not in Sweden, but actually in New Orleans in the United States with Dr. April. So I commuted for 5 years, for 4 years, 5 years really. So I would 2 or 3 times a year, I'd do a round the world trip, and living, and I sold my big flash house, and I sold my practices, and we lived in a 4-bedroom apartment, and whilst I travelled from New Orleans to Linköping to New Zealand and around for 4 or 5 years. And that's what I did. But that was if you like, the beginning of the true documentation of my primary interest. And that was that I had been a teacher for the New Zealand Manipulative Therapist Association, doing both the extremity joints and the spinal section teaching. And so we were taught primarily, and we were teaching primarily as a manipulative therapy system, the Nordic system, that's Carlton von Evian. And my teachers were Brian Mulligan and Rob McKenzie. They taught me, I got my diploma in manipulative therapy from the New Zealand NZMTA, and they were the two teachers. Brian taught the extremities, that's the Carlton von Evian system, and McKenzie taught the Carlton von Evian system for the spine. And that was up until 1976, and McKenzie then left teaching that and started teaching his own things. But that's not something that's known by most people. McKenzie himself was a very fine manual therapist, and he was a teacher in that. And he was the teacher in the spinal part for New Zealand. So that's how I got my teaching. And the only reason I started teaching McKenzie stuff is that in the last year of my diploma, I went and spent some time in the clinic, expecting him to see him doing all these manipulations that we've been practicing and teaching on the diploma course. And he didn't. He just was getting people to do their own stuff, reflection and extension and side gliding and correcting shifts and a few things like that. And I came away from that quite confused, because I was already a good manual therapist by that stage. I was lucky to be exposed to manual therapy and diagnostics as a student by a medical doctor who was happy to teach basically the Sacroiliac method, and also the manipulation method of Robert Main from Paris. And so I learned all that system before I even qualified as a physiotherapist. I was actually doing it. And so, all I wanted to do was to learn how to be a better manual therapist. And then McKenzie says, well, why manipulate everybody just to get the few who really need it? Why not just get them to do their own movements? Because after all, they are telling you that they get better with this and worse with that. So why don't you just get them to do more of what makes them better and less of what makes them worse? Seemed pretty logical to me. So that was long before he wrote a book. So I became an advocate of McKenzie on that basis, because I really saw predictable results. I think that was the thing, is predictable results. And that really got me interested. And of course, I was teaching manual therapy and manipulative therapy during the late 1970s and early 80s. And one of the courses that I did was with Freddie Kaltenborn, who came out to New Zealand, and it was a 5-day course. And he spent 2 of those days on the sacroiliac joint. And we learned his system of sacral positioning and all that stuff. And I tried to put that into practice, and it didn't work. Patients didn't get better. Not in my hands anyway. So what's the point? It's no good for me. It certainly didn't help my patients. So I stopped. And even now, if you go to my old clinic back in Auckland and you pull out the notes, you'll see these sort of drawn pelvic things with crosses on them, just in the old Cartenborn way. And I tried for 6 months, and I was seeing like probably between 2 and 5 new low back pain patients every day, that many.
Yeah.
So I saw hundreds of people in the space of about 2 years where I was doing this manual therapy for the sacroiliac joint, and it wasn't working. So I threw that out the window and said, it doesn't work. It sounds great in theory, but it doesn't work. So then I thought, I fell back on the old Sacroiliac tests, and I decided we should look at that and see if it's reliable, and that was my first big publication.
Yeah.
And then once we demonstrated the reliability, the next test was next thing was to see if it was actually going to be valid. I mean, reliability is one thing, but validity is a completely different thing. And so you needed to test that against some criterion standard, a reference standard, which was diagnostic injection. And I just happened to meet Dr. April at the McKinsey conference in Cambridge in 1995. And we were invited for the next year in San Diego to talk on sacroiliac joints for a half day. He would talk about the radiology and injections and what have you, and I'll talk about manual therapy, about diagnostics, clinical diagnostics and treatment. And so I thought, well, if we're going to be talking about this for a half day, why don't I come down to the clinic and let's see if I can predict your injections.
Yeah.
He says, yeah, you're most welcome. And so I go down there. And just before I arrived, I got a letter from Paul Dreyfus. He's a medical doctor he was in Texas at that time. And he just published a paper in Spine Journal to say that my tests were useless. And so I arrive in New Orleans, about to spend time with Dr. April examining patients with possibly sacroiliac joint pain, and after that to go to San Diego to talk about sacroiliac joint pain for half a day. And I've just been told that all those tests that I think are really great and reliable can't predict an injection. Well, it just so happens that a year earlier in Cambridge, I had shown Charles April my tests, and he had been trying those tests on his patients. So when I told April, look, I don't know even know why I'm here, because Paul has just proven my tests are useless. And he says, they're not useless. I've been doing them for a year and they are predictive. I said, oh, okay. So I thought, well, that's interesting. So I said, well, yes. Do you know this? Do you know this Paul Dreyfus guy? He said, oh, I know Paul well. I said, have you got his telephone number? And he said, yeah. So I pick up the telephone and I called Paul Dreyfus. And Paul answers, we get to talking. And I said, Paul, can I come and see how you're doing my tests? Because Charles thinks that my tests are okay, and you're saying they're not okay. So there's a difference of opinion here. I'd like to see if you're doing the same test as I am. He says, sure, no problem. So that afternoon, I jumped on an airplane and I flew to Texas, and which is, like 2.5 hour flight. And then I had to do a 2-hour drive to his town. And I arrive at midnight. The next morning at 7 o'clock, we're in the clinic with the chiropractor, a guy called Mark Michelson. And I observed him for half a day, and then I observed Paul for half a day. And what they were calling distraction, compression, and all these tests that I have sort of named, nothing like what I was doing, nothing at all. The amount of force they were using was so pathetically small they couldn't pick up anything. Yeah. So once then we go on to San Diego, we do this thing, and we decide we better do our own study. So we did. And that's what culminated ultimately some 5 years later at that publication in 2003. And this is how I became the person who apparently is the expert in sacroiliac joints. Well, yeah, I think I can diagnose these things, but treat them, that's a different story altogether. Yeah. I'm still not sure that we actually any good at treating these things, but we sure can diagnose them.
Yeah, I've heard you say that on several occasions, Mark, that treatment with the SI joint seems to be a huge barrier for us, that we're really not very good at it.
Well, largely because there are no studies. There are virtually no studies on people who have proven SIJ pain. No one to have SIJ pain. No one to have. In other words, they've had the injections or they satisfy my criteria or whatever, and then they are randomized into different treatment options like injection, like exercise, like manipulation, like just medication, like surgery for fusion. I mean, where are the studies? There aren't any. So we don't know what's good, or even if SIJ pain is a single homogeneous subgroup or not. Now, I personally don't believe it is. I think that we have inflammatory types and we have mechanical types, but those are subsets of a subset. Okay.
So what would you anecdotal experience say that that the SI joint, whenever you diagnose it, I know you're ruling out the spine first, and then you're like using your diagnostics test. So the thing is that if we're not very good at treating it, is that because you don't see people change fast, or is that because what is it that makes you, from an anecdotal point of view, say that we're not very good at treating it?
Well, first of all, back in the 80s, I was treating people alleged to have SIJ pain from the palpatory techniques,
yeah.
And I didn't feel I got good results. But then when I decided to just use the pain provocation tests to identify people who are likely to have sacroiliac joint pain as distinct from sacroiliac joint dysfunction, I found that if I manipulated them, I almost invariably made them worse. So I stopped manipulating people that I believed to have sacroiliac joint pain, because I practically always made them worse. When I used the techniques that are used for sacroiliac joint dysfunction, if you use that on people with sacroiliac joint pain, they don't get better, and they very frequently get worse. That was my experience. So then, of course, I started experimenting with getting people to have diagnostic corticosteroid injections, and some did well with that. And then there were some people who are really disabled on crutches or on wheelchairs, and we had a few I've seen who had to have fusion, and they actually did rather well, actually. The really bad ones, they would get off their crutches and out of their wheelchairs. They might still have pain, but at least they could function.
Yeah.
So there were results, but then when the trans-abdominal training system came in the 90s,
yep.
It made a lot of sense to me to use that as a conservative attempt to treat sacroiliac joint pain because of the biomechanics of it. And I did do that a lot all through the 90s. And I have to say that maybe 50% of people improved, the other 50% didn't, and some got worse. Yeah. But so that experience of the people who satisfied my criteria really was pretty average, to be honest, and that's why I don't think we do very well on sacroiliac joints.
I think that's a fair point, and it's quite interesting, because I do see quite a substantial amount of patients that's been told they have an SI joint problem, and when I ask them what they did that worked, they would normally say, I went to the chiro or the physio who manipulated it. But that goes back to what's interesting, what we're talking about today, the diagnostics. I wonder if those patients actually had an SI joint. If based on the testing on them, they would probably, and I know they've been using when the patient interprets what's going on, they've been told they have an up slip or a down slip.
And so, if you manipulate on the basis of your palpation results, you'll get mixed results.
Yeah.
Because half the time you're not even treating, most of the time you're not even treating sacroiliac joint pain. You're treating actually a lumbar spine pain.
Yeah.
I would be so provocative as to say that if you manipulate a spine or a pelvis, very hard to manipulate the pelvis without actually moving the spine. But if you manipulate the pelvis and you get a good result, you can almost guarantee it's not the sacroiliac joint that was the source of pain.
Yeah, but it comes back to us as clinicians using not reliable and not valid test.
Mm-hmm.
And that's very interesting, Mark, because we seem hesitant to change our practice, and we see this. We could discuss if that's not also what we're seeing now, that we used to be quite hooked on the pathology that was the source of the symptoms, and now we moved over. What? Yeah, we used to be. Yeah, and now we've become more aware of the whole person, and we want to. I know some people disagree with that, but it seems like we want to talk less about the structural source of the symptoms.
Oh, I totally agree. I think that it was made very, very clear by the Quebec Task Force on Activity-Related Disorders that they published their supplement, The Spine. I think it was 87, I think it was. And that was probably the first really large systematic review of the literature in relationship to spinal pain. And they found quite clearly that, in fact, one of the comments in that supplement, it's like a little book, that a patient with a with back pain could go and see 3 or 4 different doctors, all apparently specialists, and all get different diagnoses. So it was very obvious that there was no agreement whatsoever about diagnosis at all in any given patient. And so what they recommended, and this was the beginning, if you like, of the end for the respect that diagnostics had within the spinal pain community. That was, they said, don't stop trying to make those diagnoses, but try and classify people according to how long the patients have had the symptoms and how far down the leg the pain goes. And that's how they actually categorize people. How long, acute, subacute, chronic, and how far does it refer? And because it was very, very clear from the literature research that they did then, that the further down the leg the pain went, the poorer the prognosis. The longer the patient had the pain, the poorer the prognosis. And so that was the beginning of this massive body of research that now exists into the risk factors associated with a poor outcome. You'll notice that the poor outcome is the thing that has dominated that sort of research, not the good outcome, the poor outcome. Very important that they're not looking at outcome, poor or good, but they're looking mostly at what costs money to the economies of the world. And it's not a good outcome, it's a poor outcome. So they've concentrated on the risk factors associated with a poor outcome. And almost universally, studies have shown that it's psychosocial factors, not what's on an MRI, basically. And that is a truth. And I have no quibble with that. You can have a clearly defined and treatable pathoanatomy that if the patient has the wrong attitude or the wrong behaviors or the wrong beliefs, emotional responses to advice and care, then they won't do well. And it's got nothing, so the two are really, they interact with spine pain, but they are actually different dimensions. And so that is one of the, if you like, the sources of the idea of the biopsychosocial. And that is that a person in pain has almost always at least an origin of nociception, in other words, a structure that is causing nociception for some reason. And then there are psychosocial influences that affect both the experience of pain and the diagnostic and treatment outcomes. And that is a truth. And I have absolutely no problem with that. What I do have a problem with is that the people who say, well, you know, the biological part, the pathoanatomy part, that's been tried and failed. And therefore we will not consider ourselves, it's not even considered worthy. In fact, it's even considered dangerous to make a pathoanatomic diagnosis these days. And I think that's an appalling attitude.
I think that's a fair point to make. And you're right that the majority of studies are now made on prognostic factors. And as you said, the psychosocial issues seems to be whatever, if we're looking at neck pain, lumbar pain, or shoulder pain for that matter, the psychosocial comorbidities seem to be very good prognostic factors.
It doesn't help you treat the patient. This is the thing that winds me up, is that you have a person come in with a back pain, they put their back out or they hurt their back a week or 2 or 3 or even a month, several months ago, and you notice that they're a smoker, they're a bit overweight, and that they are not particularly active, and they have, maybe they get depressed occasionally, all right? So you treat that patient by risk factor? That's not of any use to that patient. That patient is in pain. They can't bend forward, or they can't bend back, or they can't turn over in bed at night. And fiddling around with risk factors is a complete insult to that patient. You treat populations by risk factors, not individuals. And that's the difference. Guidelines focus on those risk factors because that's the only evidence that apparently is available.
Yeah.
But that's not the patient. The patient is that individual human being that walks in the door and says, when I bend over, my back suddenly instantaneously hurt me and I could no longer straighten up, or I had the severe pain and I had to lie down for 2 days and now I'm getting back to work, but it still hurts. Risk factors, I'm sorry, that's not a treatment.
No, it's not a treatment, but it sometimes it could guide the advice we would give the patient. Would that be wrong?
Well, of course, but that's absolutely, like be more active and, stop smoking and all those things. Yeah, but that's not treating the reason why that patient turns up in your clinic.
No, it's flipped the coin. It's not treating the source. That's correct. So
it's not even treating the problem as far as the patient's concerned.
Yeah, that's a fair perspective. Yeah.
I'm looking for the patient. Have you ever had severe back pain?
I've had. This is not a very good commercial for a physiotherapist, but I've had back pain.
I've had several.
I've had 11 months, more or less constant back pain, Mark.
Okay, well, no, I had my first episode of back pain in my mid-20s.
Yeah.
And I've had episodic back pain ever since, which I've managed completely without ever having anything done to me at all.
Yeah.
Now, that's perfectly fine. And I've had 2 episodes so severe that it's impossible to move off the floor. Okay, I've had that twice, both in Finland when I was teaching people about back pain. I know about a back pain. I've experienced it. And anybody who said to me, "Oh, you've got to give up smoking, Mark," I'd say, "Would you do something about my pain?
Yeah,
please."
Yeah. But that's a totally different. That's another thing, Mark. That when we look at the studies, we're pretty good at. Not pretty good. We can actually discuss if we're good at anything, but if we should also give ourselves some credit. We can reduce disability, can't we? But pain, we seem to have difficult. The studies seem to be pretty poor at changing pain. Even when we look at some of the recent studies, they're showing a reduction in disability, but they're not really changing pain. So,
absolutely.
So some would argue
that there's a good reason for it.
Yeah. So, okay, I'll just finish this one, and I want to hear the good reason. So some would argue that you can actually live well with pain. I know Bronnie Lennox, who's in New Zealand as well. She's done studies of that, which is extremely interesting, why some people live well with pain and others really can't. But I think the majority of my patients would like me to help them get rid of their pain. Let's find a solution. Let's get rid of that pain and then get going in life. While some accept that, okay, we can make you less disabled, but the pain still seems to be around. But the majority would like their pain to go away. When I ask them directly, I say, what do you want out of physiotherapy? What are your expectations? I want to get rid of my pain and back to doing what I did yesterday.
Both things.
And I think I'm pretty good at helping people getting back to what they wanted to do. And I think most of my colleagues are as well. But yes. The pain sometimes it seems just to stick there.
Yes. One of the things that you have to be very clear on is that randomized controlled trials are usually done with patients who A, agree, B, are 18 years or older, or less than 65.
Yeah,
that's fine. That is fine. Which means, of course, that most of the RCTs don't give any information about people less than 18. Right? The fact you can't generalize to people outside of these age groups. The mean age for these RCTs are between 38 and 42, basically. And so people at the other ends of that scale are not well represented by the CTs, the RCTs, not very well at all. That's the first thing. The second thing is that back pain is not a homogeneous condition. It is a symptom like chest pain or abdominal pain or headache.
So have we discarded the subgroup or the specific classification because it's difficult for us, Mark, or have we done it because the literature shows us that we've failed? Is that what people think?
Well, I don't know. It's hard for me to argue about what other people think. But the reality is that this triage that Waddell basically introduced in the late 80s, is basically, when you talk to Gordon Waddell about this, and I have done some many years ago, but did talk to him about it, he told me that, he says, you know, we generated that concept of triage for GPs because they know nothing about back pain. And they kept on asking us surgeons, which patients did we want to see? And surgeons throughout the world will tell you almost invariably the same answer. Don't send me back pains. Just send me people with prolapsed discs, or you worry about whether they've got a cancer or a fracture or an infection or quarter-quinine syndrome. And so what he did was he said, look, we need to divide people up to, this is for GPs now, divide people up into the three groups: the red flags, the ridiculous syndrome people, and all the rest we'll just call non-specific, because now everybody agrees we don't know what's going on there. And so the black box of the non-specific became a diagnosis.
Yeah.
And it's not a diagnosis. It never has been a diagnosis. It was never intended to be a diagnosis. It's just 90% of the back pains that are not red flags or have a prolapsed intervertebral disc, because the surgeons don't want to see those, because they know they get lousy results with treating back pain when they try to do surgery on it. That's why they don't want to see them. So the whole non-specific low back pain category is just a black box for dumping people who don't suit surgical criteria.
And
it's
that
useless.
Kind of, so that we've kind of taken that to us and accepted the term, because we don't have what we are normally saying, that we don't have the reliable and valid diagnostic tools.
It's become an excuse for laziness.
Okay. But I don't know if I would call it lazy. I would maybe more call it curiousness, right?
Or a lack of, yeah.
Yeah, I think, yeah, and I learned that through my diplomaship, when I remember Scott Habawi telling me after like 2 weeks, you need to become more curious. You can start selling shoes in the Adidas shop.
Fair enough.
And I think I've taken that point to me the last 10 years, and it's made the fact that I'm not selling shoes. I'm curious now. So Mark, do we have the ability to diagnose a specific structure? Are there some subgroup of structures that we can fairly in the clinic diagnose?
Okay. Before you even go into that, the answer is yes and no. Okay, so I'll try and explain what that means.
Yeah.
Is that you have to differentiate between a clinical diagnosis and a reference standard or criterion or gold standard diagnosis. What we do in the clinic is what we call a clinical diagnosis. In other words, this is our demographics, our history, our physical examination, and maybe an X-ray and some blood tests. That's what everybody can do in primary care, and that's what every patient can and should get, is those things. The clinical assessment that we can do. All right, so and what can we get out of that? That's one thing. Then we have the reference standard diagnosis. Now just think about that a little bit. What's the best that our modern understanding and our high-tech imaging and diagnostic injections and all those, what's the best we can do? If you ask the question about can we identify the source and cause of back pain, the answer is absolutely we can in the great majority of patients. There's probably less than 10% of people for whom a structural diagnosis is impossible. Okay? That's using everything we've got available. Now, I've seen this, I've been involved in it, I've measured it, and I've published it. All right? Now, that was when I was working with Dr. April. We saw over 200 patients, and about 10% of people we were unable to get a diagnosis based upon diagnostic injections. So that's a very real phenomenon. There are some people for whom a diagnosis is absolutely impossible. We don't know why they hurt. But the great majority of people, if we have the facility, the skills to do MRI, CT scans, diagnostic injections of the disc, the facet joint, sacroiliac joint, nerve blocks, and all the rest of it, if we can do that to any patient, then we will get a structural diagnosis and possibly a pathoanatomic diagnosis in the great majority of patients. Now, the next thing the question is that can we predict that diagnosis with our clinical assessment? That's what my PhD was on. That's what I did. We started off with sacroiliac joint, but then we went on to do facet joints and discs and the like. So what I'm trying to say here is that if we can predict the outcome of the reference standard diagnoses, then the answer is yes, we can. So how well can we predict those reference standard diagnoses using our simple clinical methods?
Yeah.
And the answer is quite well. Obviously, we're not as good as the reference standard diagnosis because, frankly, if it was, then there wouldn't be a need for a reference standard. So which other certain subgroups where we in the clinic can be more certain that we can predict those reference? Yes.
Yeah. Which would that
be? The ones that I think that we can do very well on is we can identify people with prolapsed discs.
Yeah.
That's one. Now that's accepted in all of the guidelines. It's part of it. You just have to ask the patient, where's the pain? Is it dominant in the back or the leg? Do you have a positive neural tension test causing leg pain? What's the quality of the pain in the leg? Do you have a neurological deficit? Do a screening examination. You can do that in the clinic with every patient if you need to, and you can predict an MRI with regards to herniated discs pretty accurately. You can't predict the level, but you can predict if it is prolapsed at one level or another. And so that is in fact, most GPs can do this just as well as any physiotherapist or chiropractor or anybody else, because if you go and go to an orthopedic clinic, 60% of the patients already have the diagnosis, and they actually have that problem. Now, the prevalence of a prolapsed disc in the general population in a primary care setting is less than 10% of back pain. Yeah. But in an orthopedic clinic, it's like 60%.
Yeah.
So obviously the doctors are getting it right most of the time. So it's one of the easiest diagnoses to make. We can do that.
Yeah.
Now, we can also do stenosis, spinal stenosis. We're actually really good at that in the clinic. Now, there are refinements and there are ways of improving our performance in that regard, but by and large, good quality clinicians can identify people with spinal stenosis. It's not that difficult. It is not that difficult.
So if we stay to the stenosis, which questions should they ask?
Oh, that might take a little bit of time, but the thing is, the answer is that if you stick to our main thrust here, the important thing is what do I believe we can do in the clinic, and the two obvious surgical conditions we can identify well are prolapsed disc and spinal stenosis. Then we have sacroiliac joint pain. Now, I've obviously been responsible for a lot of that, that validation. But I think that if you follow my simple rule, and it is a very simple rule, that if you have 3 or more positive tests and people known to not have something else.
Yeah. So you rule out, like, for example, discogenic pain. You rule out people with directional preference.
Only a subcategory of discogenic pain, but centralizers and people with directional preference. If they have that, then you know it's not any positive tests are irrelevant. Yeah. And it's the same. And the reason why I knew that the provocation test produces false positives is because during the 80s, it was very clear to me. I was doing all these sacroiliac joint tests on all of my patients. And I found that people who centralized, as soon as their pain centralized, the sacroiliac joint test became negative. That was the first thing. Yeah. And the second thing was that people with prolapsed discs clearly had prolapsed discs. And you do these tests on them and they were positive. Well, of course it's not. It's got nothing to do with the sacroiliac joint.
No.
So I knew that false positives were an issue, that we had to somehow have a reasoning method by which we can use the sacroiliac joint tests without getting all these false positives. And so that's all I did. It's not rocket science. It was, if I could work this out, hell, anybody can work this out. This is not that difficult.
So you're saying if a Kiwi can do it, anyone can do it?
Well, I don't know about other Kiwis, but this Kiwi's not that smart. The important thing here is that we now have measured our ability to do that, and even now I'm much better at it than I was when I did those studies.
Yeah.
But but our data shows us we get it accurate. Our accuracy 77%. But that's not bad in relationship to a reference standard. To say you can't make that diagnosis, it means that you're not trying.
Yeah, and that's what worries me about the non-specific, Mark. Sometimes when I can't sleep, I think about that, is that you said the word lazy, and I used the word curious. And I think that's my worry, is that when we're only applying the non-specific, if we should argue not to do that, my worry is that people are not gonna like find sinister pathology or radicular pain. To me, that's a larger problem than like overlooking a facet joint, for example.
Oh, sure. Oh, without question. But the triage, the general guideline management, does recognise the fact that with the red flag management, is that as soon as a person has one or two of these things, then we need to go and get imaging and all those sorts of things, which is fine.
Yeah.
But of course, once a person doesn't have any red flags today, they might do in a month's time, when the patient has been called non-specific low back pain and is having chiropractic care or physiotherapy care or just being put on pills or something like that, and they're sitting there while their cancer grows.
Yeah, but that's another thing, Mark. Like, if you're not curious, if you're not doing, I would always advocate, or not always, that's stupid to be black and white, but often I would advocate for a thorough mechanical examination, because we know the sensitivity and specificity in the subjective history of red flags is pretty poor.
It's not that flashy, but no.
No, it's not at all flashy, to be honest. So if you're saying, okay, there
are very serious limitations on that data, by the way.
Yeah.
So we say it's not that good, but that's a one-time red flag assessment. But if you are constantly paying attention to the emergence of red flags and you don't miss them, then you're unlikely to inadvertently fail to see these things.
Yeah, that's a fair point. Yeah. So my worry is just that if we're saying, well, there's no red flag on the initial visit, and we'll just start out a management plan without really knowing what we're having within our hands and within the scope, I think we're not giving individualized care. We're giving guideline care, and we're not really actually very good at it. And the guideline, as you said before, is so unspecific, so it's not directed at the individual person. So that means they're
guidelines. What? They're not prescriptions. They're guidelines. Yeah,
they're guidelines. But the fact is that the guideline is like more like a minimum of what you need to check.
Absolutely, it's a minimum.
Yeah,
a very minimum. And you made in your comments when we were having this discussion before we agreed to talk about the impact study, and that's a study done out of Kiel University. Very good studies. I mean, this is good science they're doing, and what they have identified, what they have accepted, is that the psychosocial variables are the predictors of outcome. And so when you are seeing patients, the broad spectrum of back pain, from the minor little niggle pain that the patient comes to the doctor and says, well, my back's been a bit sore the last month. And they say that, I've come in for my heart attack, but really my back's hurting me a bit. So, well, okay, you need to go and have some physiotherapy. And so they go and get massage and what have you for their back pain. It's that sort of minor, irritating low back pain that just comes and goes and is casually mentioned to the doctor. That shouldn't be treated with an MRI. That's just insane. And yet it so often is.
Yeah.
And so their idea was to try and take our risk factor assessment, which is the start back tool, which is a good tool, and categorize people into a low, medium, and high risk of a poor outcome. And we will structure the cognitive behavioral therapy component of what we do according to those risk factors, and that's eminently sensible. But if you have a look at what they recommend, is that basically if you are in the low risk factors, the low risk category, and that's only about 20% of people, by the way, it's not a big percentage. If you are in that category, then basically you just get told is a good prognosis and don't worry about it, and you know, keep active and stop smoking and blah, blah, blah. Perfectly good advice until the patient comes back 2 months later and says, well, you know, it hasn't got any better. Now, that patient automatically then goes into the medium risk, in my opinion, but they may still be categorized by that tool as low risk, but they should automatically go into the medium risk, not because they have psychosocial factors that are positive, that they probably don't, but they have proven by actual experience that their problem is not going away.
Yeah.
That person deserves a full assessment, a full assessment. And actually the medium risk factor group actually get that with the impact studies.
Yeah, it does, yeah.
So we can use that really, really good research that's been done, not necessarily be slavish in just following their rules, but actually try to understand what they're trying to do. And I think we can use that. It's good information.
Yeah. That's also, you must have seen patient 2, Mark, that's like been stratified by the GP or by a physiotherapist like us, been told that prognosis is good. And then, as you said, they come back 2 months later. Yes. And most of the patients I see, no matter high or low in society or active or inactive, they're like, I was given this general advice and it seemed logical at the time that it would go away. And now like 2 or 6 months later, it's still here. So there's also a substantial amount, I would say, that doesn't really fit the criteria that it will just automatically go away within 6 to 8 weeks.
Absolutely.
And the same people where it does go away, they're not always told that it's recurrent within 12 months for like 60%.
At least 60%. That's true.
Yeah. So
in that study by Hodges and Hydes and whatever, where they looked at the first episode of back pain, the recurrence rate was 80% in the first year. Yeah.
And I think if we're going with that the prognosis is good, we still need to be able to be, and I know I'm going to get hammered for this, but I think we still know to look at the individual. We're saying that too, because they can have, like, we're okay with saying they can have prognostic in regards to psychosocial, but they would also have physical impairments that telling us the prognosis is not so good. I mean, how many times haven't you seen a herniated disc that's been told prognosis is good? And we know because they have their leg pain, they're less likely to have a good prognosis than just regular back pain.
You know, there's one thing here that's very important to realize, is that a good prognosis is a statement about the average, about the mean values. And my patient, every patient who walks in my door is not that mean average person. That is an individual who has all sorts of shit going on in their head that you know nothing about. And the important thing here is that RCTs, systematic reviews and meta-analyses, all of these things talk about mean values. And mean values mean that some are better and some are worse than the mean value. Okay? And if a person on average is expected to get better, that means that there's probably at least one standard deviation that's going to get worse.
So how will we like, because what I've heard sometimes now, and I heard Roger's talk yesterday with Ben Cormack talking about the RCT, and it seemed, and I've actually heard Mark Wernicke talk about it as well. You know Mark?
Yes, I know. I've never met him actually, but I know he's worked well.
Yeah. Talk about that what we're trying to do, we're applying the RCT from the medical, how it was developed, we're applying that to physiotherapy. Yes. And now I've heard like three patients or people that's been in the game for quite a while saying more or less the same, that it's not really that good.
Let me tell you a little story about the time that I had too many beers with my Bart Coase.
Yeah.
And this is in Lillehammer at the IFOM conference in 1996. And we had just seen published in the New England Journal of Medicine the comparison of the McKenzie approach versus chiropractic versus a $1 booklet.
The Cherkin study.
The Cherkin study, indeed. And we had discovered that the McKenzie approach was no better than a $1 booklet. All right. So I'm sitting there drinking beer with Bart Coase. And I said, Bart, you're the statistician. I'm a clinician. You're the statistician. You're the guy with the brains. You tell me why a booklet is just as good as everything that I've been thinking I've been doing such a wonderful thing on for all these years. And you tell me, you're the brains of this outfit. You tell me, because when a patient walks in the door with a lateral shift, I know how to treat that. A person comes in and they do push-ups and the pain goes away, and they bend forwards a few times and the pain comes back, and they do push-ups and the pain goes away again. And I tell them, do the push-ups and don't do the knees to chest. Or if it's the other way around, I tell them that. You tell me that what I'm doing doesn't make any sense. But your $1 booklet, according to the statistics, on the average back pain is just as good as a chiropractor or a McKenzie practitioner. And he says, I have not the faintest idea. And I said, well, don't you think there's something wrong with the fact that you're talking about averages and actually there's no such thing as an average back pain patient? Don't you think that might be something to do with it? That was obvious to me in 1996. And ever since then, I've been beating the same damn drum, is that back pain is a symptom of conditions. And if you think about it, just think about it now. If you had maybe 30% of people have back pain, and 20% of people have sacroiliac joint pain, and 20% have facet joint pain, and 20% have something else, and then you have a treatment that's really good for back pain of discogenic origin, and you apply that to all of those patients, you're only going to get a 30% recovery rate. That's terrible. What a lousy result. But for that 30%, it's brilliant. Now, on average, though, it's no better than acupuncture or waving gems over them, or coloured lights or something. And that's what RCTs do. They lump all of these people with the same symptom in together and treat them as though they were homogeneous.
Yeah.
And it's just not good science. It's lousy science. It's time to change. We have to stop doing that.
So going to be very academic now, what would be a good method, like, to study these things? And with that, I mean, from my perspective, we would need to believe of course, find the data that we could subgroup, and then do studies on subgroup.
We have done that.
What?
There has been studies on subgroups, but mostly psychosocial subgroups.
Yeah. Yeah.
And we have found that, as you say, we can change disability, but not pain.
No.
So what to me the logical conclusion is that disability is a psychosocial construct, and pain is a different one. I don't think that that's particularly revolutionary, but it sounds reasonable to me.
Yeah.
The fact that pain can make people disabled, or if people who are disabled don't function well, so maybe they get sensitized and therefore have more pain. The fact that they interact doesn't alter the fact that it's quite clear from the RCTs that if you manage risk factors, psychosocial variables well, then disability does improve.
Yeah.
It's not dramatically, it's not huge, but it is a significant effect. We know that. Now, I think the most recent one that I'm aware of is the one that where Peter O'Sullivan looked at cognitive functional therapy approaches, and he quite clearly states in their papers that they've published very recently that yes, we can do something about disability, but the pain really doesn't change that much. Yeah. Now, and that's totally believable to me. I don't see that this is such a surprise.
If you expect there to be a connection between psychosocial issues and pain, then you
there is, but it's not causal.
No, yeah.
Well, hold on. To be fair, it may be causal.
Yeah.
For example, if you have pain that's severe for 10 years, if you're not depressed, you're an unusual individual.
Yeah. So it comes back to not being black and white, and we seem to be pretty much on either side of the pond, Mark. So if we should embrace more or less.
What side of the pond do you think I'm on then?
I didn't say that you and I or somebody else.
People often say that I'm on the pathoanatomic side of the pond.
if I look at sometimes the hammering you get on Twitter is that you're too much into the bio part, and some would argue that.
It fascinates me.
Well, yeah, it's fascinating. Yeah, but that's what I mean. Twitter is also a media that's like really rough to people, and sometimes I get off it in a few weeks because it just gets too much. But it seems like because we haven't had success so far, and I don't think we've had success because we've more or less tried to change the paradigm to being more psychosocial, and came from
the paradigm has changed. It has definitely changed.
Yeah, and for the better, I believe.
Oh, I think so. I think I think we are better at managing patients.
Yeah, but I think what's being said sometimes, and maybe it's said because we really want to make it clear that it's important. Then we're emphasizing the psychosocial factors more, just like when Mackenzie in the 80s started emphasizing that the patient should be educated and help themselves as one of the first, and then people.
He was the first person to actually understand that. He was the first person to understand it.
Yeah, but people understand him now, and one of the myths is the fact that he never puts hands on people, and you don't do that. So that. Well,
that's not true. He always did.
And I know that, Mark, but what I'm trying to say is that maybe in my poor English is the fact that when we want to change things or we sometimes make pretty harsh statements, and we don't really embrace the whole thing that we actually mean we have to.
Sure.
We're trying to push in a change. So we're really like kind of missing the dialogue, especially on Twitter and other social media.
Well, for Twitter, you've got 256 characters. It's a bit hard. Anyway, you don't want to have to write an essay every time you ask a question.
No.
So what else do you want to talk about?
I want to talk a bit more that if you had a patient, Mark, if we should go back to the N equals 1 talk, and you had a low back pain patient coming in your door. They had back pain and they have left buttock pain. They were acute. They've had it for like 2-3 days. It came out of nothing. They just woke up with it. What kind of things in the subjective and the objective history would kind of drive your diagnostic workup?
Okay, we're talking about a back pain patient with buttock pain but no leg pain.
Yeah.
Right. Okay, the first thing that I do, actually, I only see really long-standing patients now. I don't see acute pains anymore. I practice I have a specialist practice. I don't practice in the primary level anymore. But now all of my patients, every single one of them, acute or chronic, do a suite of questionnaires before they even get to the clinic. They do it online, and a report is generated, and that basically is there for me. And everybody gets the Roland Morris. They get the sensitization inventory. They get the pain detect questionnaire, and they get their red flags done, and they get their pain intensities done, and all those questions about inflammatory back pain, all the rest of it. So that's all done before I even see the patient. So 20 minutes of my time is saved simply by getting people to do a few questionnaires before they even come to the clinic. Now, that's not possible necessarily in primary care, but it's certainly the way I practice now. Now, the person has only back pain. I probably wouldn't do a neurologic screening examination, although I actually do it anyway because it's very quick, takes 2 minutes.
And you're curious.
I do it because it's so quick and easy, and it means that I can rule it out and it's gone. Okay. But if the person has buttock pain, I want to know if the buttock pain is dominant or the back pain is dominant. I want to know where the pain began. Did it begin in the middle of the back and then move off center, and down into the buttock, or is it always been off center and in the buttock? I want to know how it began, what the progression of that has been over a period of time, and of course I'm interested in what effects those things have on their pain, on movements and positions have on their pain. So that's the first thing. Then when I will look at them, and the first thing I'm trying to look for is the shape of the lordosis. Is there a lateral shift or not? Because if there's a lateral shift, then I correct it. I don't piss around. I get on with it. All right. There's no point in trying to give people exercises if they've got an acute lateral shift. So I correct that and deal with it. And it's usually correction of the shift and restore their extension. And a person with acute back pain and buttock pain that's of short duration like that, 95% of the time, they turn around very quickly within days. Now, that may be maybe 50% quicker than if you just left them alone. But it is quicker to actually treat it that way. Many patients with a lateral shift will spontaneously recover without me doing anything to them.
Yeah, that's my experience.
Oh, it is. It was Mackenzie's experience too. But why wait?
Yeah.
Because you don't know if the patient's going to still be there 3 months later with a big shift. And then it's really hard to treat.
Yeah.
So I deal with it right away because you can and because it rapidly makes a big effect. And the patient is eternally grateful and they listen to you when you give them advice about what to do and not to do. So it has a lot of reality to the patient when you move in there and deal with it. If there's no lateral shift, I want to do things like the extension rotation test, not because it's diagnostic of anything, but because if it's negative, if there's no pain with doing extension rotation, we know the facet joint's not the cause of pain. We can rule it out. We've demonstrated that. That's published stuff. This is not new information. And then, of course, I will do my repeated movements assessment. And I'll do that with every patient because I want to know if there's a directional preference or the pain can be made decentralized. Both of these things, we know what the pathology is, but we don't have to know that it's the disc, or even though we do know it. But we know that if we can make that happen, particularly if it's a reversible phenomenon, if we can cause, say we do flexion 10 times and the pain gets worse in the buttock and less in the back, and then we do extension and the opposite happens, and then you do the flexion again and it comes back down, gets worse again, then you do extension again and it gets better again. Well, by the time I've done that, actually reversed it twice to the patient, I'll say to the patient, well, you've seen what we've been doing here. What do you think you should be doing? Do you think you should be bending forward to get this better or bending backwards to get this better? And they'll say, oh, no, you've got to be doing this.
Yeah.
I said, well, why are you sitting like that? Why aren't you doing these exercises? Well, nobody ever told me. Well, fine, I'm telling you. Do it. And don't do the ones that make you worse. And you can predicate your treatment on that, and it's really, really simple. And it's extremely understandable to the patient. They have a strategy to leave your clinic with for the next 24 hours, and I will see them the next day if possible. I don't wait a week. I see them the next day, acute back pains, because they almost invariably don't get it right.
Yeah.
Patients, they come back the next day, even though you've spent 20 minutes explaining, do this 10 times, take your hips off center, do all that stuff that we do as Mackenzie therapists, and they come back the next day and they're doing something else. They're also doing the knees to chest when they shouldn't be doing that, and stuff like that. You know this stuff as well as I do.
Yeah.
So I see them the next day if I can, or certainly no more than 2 days away, so that I can reinforce the pattern, demonstrate it again, and then they go away and they start to learn how to look after themselves. One of the biggest mistakes of Mackenzie practitioners or people who believe they are Mackenzie practitioners is that they just stop there. Mackenzie himself was very clear. You have to restore function. So at a certain point, you need to restore the ability to bend forward. Or if in the case you've been giving them flexion because they're an anterior derangement, for example, then you have to restore their extension. So you have to restore all movements at some point. And that's something that's often missed. Yeah,
and I think it's one of the things that the people that don't like the method is like we're saying, well, you're not making people going back to normal life again, you're just extending them.
Well, Mackenzie had no problem with people going back to their normal life. He wanted them to be able to flex. Yeah. You can't live your life without flexion.
No, it's going to be pretty hard, no matter how hard. Well, I guess sometimes. You want to
try having sex without doing flexion, huh?
Yeah. So Mark, are you in your diagnostic process? Are you driven by data in the way that you're looking at prevalence, where we have data that says so much is like discogenic, or we know that this is more likely because of location to be facetogenic, or how does that work up in your top floor?
It's not precise because, for example, we know that more people have discogenic pain than have facetogenic pain. Or sacroiliac joint pain. We know that that's generally true. The exact percentage doesn't matter. What we do know is that as soon as a person has 3 or more positive sacroiliac joint tests, that the likelihood or the probability that it's sacroiliac joint pain increases.
Yeah.
From whatever it might be. Now, we also know if a person happens to be a female who started getting their pain during pregnancy or shortly afterwards, that the probability of them having sacroiliac joint pain is probably over 50%. So if they then have 3 or more positive sacroiliac joint tests, that just about makes your diagnosis right there without even doing the other stuff. But if the person comes in and they're 65 years of age and they don't have the probability that a 65-year-old will have sacroiliac joint pain is actually very low.
Yeah.
Maybe less than 5%. So if the person doesn't have sacroiliac joint tests that are positive, it virtually rules it out instantaneously.
Yeah.
So what we're doing is we're shifting probabilities, but we're not fixed on a figure. We don't have to be fixed on a figure. We're just saying, well, what's more probable? What's the most likely thing? Then that's fine.
Yeah.
We don't have to do a lot more than that.
But that also comes back to being curious and want to know more, Mark, because then you can do that with probability, and you're still not stuck in the non-specific, so to speak, because you're not being so generic that you're not using your probability.
Absolutely. The patient who walks in the door for the first time, that is your non-specific patient before you know anything about them.
Yeah.
As you know more and more about that patient, if you like, as you exercise your curiosity, then the probabilities shift and change.
Yeah. I think that would be fair. Yeah. So Mark, we're about to be at the end now, and I have this question to most of the people that I'm able to chat with. If you were to give my undergraduate students that are almost done, what would you advise them to do on their path as becoming good clinicians? It's a big one, I know that.
I think the first thing that I know that most undergraduate patients are probably quite good at taking a history. I think that they're probably okay at doing that. By the time they are near completion of their physiotherapy degree, they can probably take a history that's reasonably good.
Yeah.
I would want them to be able to do the provocation tests properly. And that they are often talked about, but they're often done very, very poorly. There are a few videos on YouTube that talk about the Laslett cluster, which is something I never named it. I never did that. But anyway, and some of them are quite well done, and others are terrible, shocking.
Yeah. So
you don't rely just on YouTube. You need a good teacher who can teach you how to do these things properly, because there is a good way to do it and a bad way to do it. You need to be able to do the repeated movements assessment. You need to be able to find directional preference and centralization. If you can't do that, those simple things, a neurologic screening examination, the pain provocation tests, and a repeated movements assessment, if you can't do those things, you shouldn't be treating back pain.
Yeah, thank you. Yeah,
I don't think that's particularly rocket science. That, to me, the evidence, what evidence we do have, and it's pretty weak overall, but what evidence we do have suggests that you need that information.
Yeah, yeah. I think you're right about the SI joint test, or I agree on most of the things you said. But the funny thing, when we're performing it, when we're training with our undergrads, they normally look at us and say, like, do we really need to push that hard? And
well, the answer is yes and no.
Yeah.
If you put a little bit of pressure on the patient, says, oh, that's my pain, you don't need to press any harder.
No. But all our students, I mean, they don't have the pain, and they're pain free. So when we're testing on people without symptoms, we need to put a lot of pressure on it. And I remember asking you the same question back in 2006, and I was like, he's putting quite a substantial amount of pressure on that SI joint.
You know, it is the strongest joint in the body.
Yeah.
It is the largest area, has the largest surface area of any joint. And other than pregnant women and women not recently pregnant women, it actually is really strongly bound together by very, very strong ligaments, the strongest ligaments in the body. And if you are hoping to stress that structure with pathetic little movements, forget it.
Yeah. So
if you want to rule out sacroiliac joint, you have to apply substantial force. There's no escape.
No. So Mark, we're a bit about the end now. Where can people get to know more about you? Where do you hang around? What are you doing for the future?
Well, I mean, I'm 70 years of age. I could be dead tomorrow.
It's been a pleasure.
But no, seriously, you can follow me on Twitter. That's one thing. Southern Musculoskeletal Seminars has a good website, and you can follow me on my Facebook page. I've got lots of nice videos on there about this. There are videos of me doing the sacroiliac joint tests. There's a test there that I've never tested for validity or reliability. That's the belt test, which is one that I developed myself, but it's never been tested. I've never done it, but I use it all the time in trying to evaluate whether a person has an unstable pelvis versus a painful one. There's a difference, and so that's well described on that there. You can on ResearchGate, I have most of my papers available for people requesting those papers. If they can't get them through the universities, that's not a problem. But the websites, my Facebook pages, we are trying very hard to keep those up to date. Certainly the course material, if you want to learn about diagnostics, I've just 2 weeks ago, I have a new course called Diagnostic Accuracy, the Science of Diagnostic Accuracy. It's an 8-hour course. And at the end of that, you should be able to understand sensitivity, specificity, likelihood ratios, the pre and post-test probabilities, and the reasoning process. And we haven't talked about this reasoning process. To me, I go from pattern recognition to spin and snout, and a thing which I call diagnosis by subtraction, which is what most expert clinicians do when they diagnose. If they haven't recognized a pattern, like, a person comes in with a shift, that's a pattern, right? Or a person has a prolapsed intervertebral disc causing leg pain, that's a pattern. If you haven't got a pattern, then you start looking at all your highly specific tests to see if any of those are positive. And if they are positive, then you know what the problem is. The diagnosis is made. If you have none of those, then you have to start ruling out things. For example, well, if it was sacroiliac joint, surely one of the sacroiliac joint tests would be positive, right? Or you look at your notes, they're all negative. Good, you can rule that out. And what you start ruling things out. And then at the end of that process, you wind up with either one or two possible diagnoses. And there's one of those, if you've got two left, a residual diagnosis, clinical diagnosis, then there's one that's going to be much more probable than the other. And you can pursue that diagnosis, or you can predicate your treatment on that diagnosis if you want to. So to me, there's a process which is described in that 8-hour course. And that 8-hour course, we give you the opportunity to actually create a 2x2 contingency table from real data, which has never been published, but it's my own data. And you get the chance to actually create that. We show you how to do it, how to extract the information, calculate the sensitivity, specificity, interpret that, and the likelihood ratios and all the rest of it. And we also teach you how to critique diagnostic accuracy studies. So that's just a new course. It's only been out 2 weeks.
And that's on the Southern Musculoskeletal?
Yeah, it's www.musculoskeletal.courses.
Okay. I'll put that in the show notes.
I can give you that. Those links, and of course you can follow me on Twitter. That's easy. I mean, I usually spend up to an hour every day on Twitter. So
okay, I think my wife would kill me if I did that.
Well, I'm allegedly retired.
So you actually finish with patients like 2 o'clock, and then you stay there for an hour on Twitter, I guess.
No, I do it the first thing in the morning, actually. Yeah, I get up while I'm having my breakfast. I'm doing Twitter.
A good thing, Mark. Good, you're keeping us busy. Yeah. Mark,
I wish you extremely good fortune with regards to the COVID-19 thing and all the listeners. We in New Zealand are very, very fortunate. We now have only one active case in the whole of New Zealand.
Oh, yeah, but you really locked it down early, didn't you?
Yep. Yes, they did a good job. We locked it down for 5 weeks and closed the borders as quickly as we could, which is not an easy thing to do.
No.
And especially for a tourist economy, which is what we are.
Yeah.
And so that caused all sorts of problems, of course, but it worked. And
yeah.
We now have only one active case. 22 deaths only.
Oh, that's not much. I think we're about to have like 600. But we're gradually reopening over the last 4 weeks, and I think it's going really well, actually. So thanks for that.
I understand that the Danes have done a good job as well. I don't know about Sweden. Have they done well?
They got I think they got more than 5,000 dead.
Really?
Yeah, but they're very they haven't really closed that much down. And I think it's difficult to. I'm not into this, and I'm not a statistician, so I don't know how it's going to look in a year.
Yeah.
So who's done the best? I think it's difficult to say. Despite the fact that we like to compete with Sweden, I think this is an area where we shouldn't talk about competition and doing.
Well, no, it's not a matter of competition because it's all a learning curve, and I think that when the next one comes around, as it inevitably will, hopefully we can look back and look at the COVID-19 and say this is the best way to handle things.
Yeah, hopefully learning by history, Mark.
One thing we have learned from history is that people never learn from history.
And by that quote, I'm going to thank you very much for the ground we covered, Mark. It's been an absolute pleasure, as always, talking to people that know a lot more than I do.
Well, I've been around a lot longer.
Yeah, that's true, but that's not the same as you learn. You actually just said that yourself.
Well, hopefully with age comes wisdom, but not always.
Not always, Mark. Not always, I believe. Mark, I wish you a very happy day, and once again, thank you for your contribution to the profession and to this podcast.
It's a pleasure. You take care now.
Yeah, you too, mate. Bye.
Bye-bye.